Good evening, students. I welcome you to the webinar on physiology of hearing and balance. The in the inner ear, cochlea is concerned with the hearing, and lateral semicircular canals, superior and posterior semicircular canal, along with the vestibule, is concerned with the balance. So we'll see the physiology. See, sometimes if water goes inside the ear and you get ear blocked or block sensation, you feel very absurd. Yes or no? Yeah. Hearing is one of the important sense organs. Like the vision, hearing is also one of the very important sense organs, which makes our life complete. So, the process of hearing we can divide into sound conducting mechanism and sound converting mechanism. That is, conduction of the sound, mechanical sound, and converting it to the electrical energy or action potentials. So, pinna, external auditory canal, tympanic membrane, ossicles, until the stapes, these forms the conducting mechanism. If you remember, in a previous class I explained, the organ of Corti, that is a receptor where the ear cells will rub around the tectorial membrane, producing the action potentials and converting the mechanical sound to the electrical energy or action potential. And it is transferred to the brain, where our auditory cortex comes to know about it, it interprets that, and we are able to perceive the sound. We'll go one thing. We'll discuss now about the conductive thing. That is the pinna, what are the pinna, external auditory canal, tympanic membrane, ossicles, stapes, okay? Then we'll discuss about the peripheral receptors. Pinna has a wonderful role. It collects the external sounds and transmits it to the external auditory matters. See, in animals, you can see a rabbit, long pinna or long earlobes. In the animals, most of the animals, even in humans, this pinna helps in auditory localization. All of you, if you want to check, just press your pinna backwards and see the way you perceive the sound. Okay, press the pinna and you see the way you perceive the sound. And make the pinna like this, the way you perceive the sound. You might have seen making the hand whenever the elderly people are unable to listen, they make their hand like this. Okay, this pinna helps in localization of the sound and it is a reflector of the sound. After the pinna, the external auditory canal also plays very important role. It has a occlusion effect. See, while we do tympanoplasties, we do something called as canalplasty. We make big canals. This increases the sound perceived by the patient. Okay. Now, the sound after passing from pinna and external auditory canal should pass through the vibrates or tympanic membrane and it passes through the ossicles and reaches the stapes. Imagine, lot of sound whenever we speak is dissipated in the atmosphere. Very little sound comes from the pinna is able to collect, and our external auditory canal is also not straight. It is S-shaped. Okay, it is curved, little bit curved. So very less sound reaches the stapes footplate. And tympanic membrane also as such can give rise to impedance. Okay, your impedance means resistance. So nature has devised certain mechanisms to amplify the received sound. Mechanism to to amplify the received sound. This mechanism is called as the impedance matching. Okay. What is impedance matching? Impedance means resistance. Resistance matching means methodology to amplify the received sounds. It is by two mechanisms. Mainly, there are many mechanisms. Two mechanisms play important role. One is called as the ossicular leverage, and second is called as the hydraulic action. Ossicular leverage is between the ossicles. Hydraulic action is between the malleus and tympanic membrane. It's because of the tympanic membrane. You can notice the tympanic membrane vibrates and the ossicles vibration is passed to the ossicles to the stapes foot plate. You can notice tympanic membrane is 14 times the size of the foot plate of the stapes. It is 14 times. Okay, this is called as this gives hydraulic ratio. Okay, and ossicles, the malleus and incus. Okay, malleus, angle of malleus is 1.3 times the incus length. So this gives us to ossicular leverage ratio. So when we multiply 14 into 1.3, we get 18. This is called as the transformer action. Means the force is increased by 18 times. Remember the word. The force is increased by the 18 times, the force of the sound. But the amplitude decreases. Okay, the amplitude decreases, but the force increases. There are other mechanisms which also aids this, such as the stapedial reflex. Stapedial reflexes. Okay, the stapes muscle from the pyramid origin attaches to the neck of the stapes and it dampens the very high-end sound, protecting the cochlea. It also aids in speech recognition and modulation of self-monitoring of voice. Even tensor tympani, which tensors the tympanic membrane, aids in listening. Essential tube, when you yawn or essential tube get blocked, you will be unable to hear it properly. So, essential tube helps in pressure changes and help in conduction of the sound. Okay. So, till now we are straight up to the stapes foot plate. The air comes, tympanic membrane vibrates, and see, remember, because of this action, malleus is also called as hammer, incus is called as anvil, and stapes as stirrup. And when the sound passes after transformer action, that is by 18 times, the force is increased to the 18 times, it passes through the perilymph. Okay, you see this picture. And here helicotrema, it turns back and it reaches the secondary tympanic membrane. Okay, round window. When vibrations pass through the perilymph, the basilar membrane, okay, vibrates. The basilar membrane starts vibrating, which makes the air cells, okay, to vibrate, and it drops towards the tectorial membrane and action potentials are generated, and it passes through the auditory nerve, okay, and this when reaches the brain or auditory cortex, it interprets the sound. So this is the one of the beautiful picture you come to know. You can see when the tympanic membrane vibrates, in the wall window stapes foot plate create the vibrations, and it passes through the scala vestibuli and turn back over the cochlea, turn, and it reaches the scala tympani to reach the round window. In this movement of the perilymph, the basilar membrane, okay, vibrates, which causes the ear cells to organ of Corti, okay, ear cells to vibrate over the tectorial membrane, and this causes the production of the action potentials. In this picture, you can see the shape of the cochlea. It is rotated like this. Okay. See, whenever you draw the picture, two-dimensional pictures in textbook, you feel cochlea is like this, rotated one above the another. The terms are one above the other. No, it is like this. Okay, it is pulled apart. Okay, cochlea is pulled apart. The rotation comes like this. To understand this anatomy properly, you will do nothing but the cochlear implant culture. See, when air cells vibrate over the tectonic memory, action potentials are generated. What happens is, you can see in this picture, the perilymph has a sodium rich, like the extracellular fluid. It's like extracellular fluid. And the endolymph is like the intracellular fluid. It is rich in potassium. Okay, it is rich in potassium. So there is a electric gradient of 80 millivolts between the perilymph and endolymph. And one of the most common questions they ask is regarding theories of hearing. There are four theories which explains the hearing mechanism. First is the place theory. Place theory says that the specific place on basilar membrane produce specific pitch. Specific place on basilar membrane produce specific pitch. This is called as the place on the basilar membrane. Next comes the telephone theory. Pitch, it states that pitch depends upon rate of firing of individual nerve fibers. That is pitch or frequency, the way we hear depends upon rate of firing of individual nerve fibers. This is called as the telephone theory. Third is the Wally theory. Wally theory combines place theory and telephone theory. It says that higher frequencies are pitch by place theory and express the lower pitch by telephone theory. Okay. Last is the traveling wave theory. Traveling wave theory states that as sound travels in cochlea, it increases in amplitude before dying. The part in cochlea where maximum amplitude is produced, there it stimulates the ear cells to produce action potential. Okay, these are the theories of hearing. So now the action potentials are produced and it passes through the cochlear nerve. Okay, and it goes to the pons and reaches the auditory cortex. So the action potential have gone from the cochlea, that is the organ of corti. It travels via the action potential, travels via the auditory nerve, then it reaches the pons, superior olivary nucleus. Now superior olivary nucleus, it ascends via the lateral lemniscus and it reaches the inferior colliculus and reaches the medial geniculate body to reach the auditory cortex. Remember the mnemonic SLIM, SLIM, SLIM auditory cortex. So the auditory pathway is cochlear, then it goes to the from cochlear nerve to the SLIM, superior olivary nucleus, lateral lemniscus, inferior colliculus, medial geniculate body, and it reaches the auditory cortex. This auditory cortex is called as the Brodmann's area 41. Okay, which area? Brodmann's area 41. It's in the temporal zone. So this completes the mechanism of hearing. Next, we'll go to the vestibular system, physiology of the vestibular system. Dear students, the vestibular system is very interesting. I don't know, unfortunately, very few people understand what it is. It's very simple. In a very simplified manner, I will try to explain to you people rest of your life, you should not miss not even a single case in your clinical practice. Okay? Very simple way, I'll explain it to you. See, cochlea is anterior. Okay? And the posterior part is, we have a saccule, atrial, and semicircular canals. This atrial, saccule, and semicircular canal gives us to gives us the orientation in this three-dimensional space. Okay, now I'm sitting. This orientation I'm sitting is comes from this. Okay, vestibular system. Our balance. See, how you come to know you're standing, you're sitting, you're sleeping. This idea comes from the vestibular system. So the vestibular system, the idea of the vestibular system, a three-dimensional space, is 90% by the this vestibular system in the inner ear, some 7, or you can tell 5% from the eye, ophthalmological input, and spine, proprioception. Okay, this gives us to 5%. Okay, some books have mentioned as 80, 10, 10. With the way you want, you can take it. Vestibular system. Okay, it is these small lateral semicircular canals gives us orientation. Whether you are flying in the air, swimming, everything is by this lateral semicircular canal. Very interesting. So before that, all of you try to remember an aeroplane. So our body is also like a aeroplane. In a three-dimensional space, this is a mechanism, the way we interpret the space. So the cockpit, you can compare the cockpit to the eyes. You can compare the wings to the inner ear. Okay, that is the vestibule and semicircular canal. And back. Okay, this is the vestibular spine. You can compare this body and the tail is to the spine. This is the vestibular spinal reflex or proprioception. So eyes is the 10%, ear is the 80%, spine is the 10%. So if imagine this ear gets damaged, this wing gets damaged. Okay, what will happen to the aeroplane? What will happen to the aeroplane if this get damaged? Yeah. Okay. If this get damaged, then automatically the plane will turn towards the right side. How does the plane? Plane will turn towards the right side. Clear? So this is the same way. If the inner ear, vestibular labyrinth, that is get damaged, our body starts turning from the right side. So then this wing, this ear, okay, the right wing is damaged, right ear is damaged, then left wing start taking the function, its function, and eye should start become more, much more, have a bigger role to play, and spine has a much more bigger role to play. Okay, so the plane starts seeing, turning towards the left side. The plane starts turning towards the left side. So the nystagmus, the first component of the nystagmus is on the left side. The slow component of the nystagmus on the right side. The disease side is the slow component of the nystagmus. Okay. The fast component on left side. The slow component on right side. Okay. So right ear damage. The direction of nystagmus is on the left side. The diseased ear is on the right side. So the patient, whenever he does the standing state, walking test, the patient will start moving towards the left side. So these are all these three. Okay, eye, ear, and spine is attached to the cerebellum and the cortex. Okay, these are attached to the cerebellum. You got the idea? If you remember this plain principle, rest of your life you will never do mistakes. Rest of your life you will never do mistake in identifying the patient. So if patient का right side में inner ear damage है, patient will rotate on right side. Everything will start turning on the right side. Then if the patient eye will be nystagmus on the other side. Okay, this is a key thing. So these three things along with the ear, eye and spine maintains the three-dimensional balance. Okay, this is a very important role in old age when they wore the sticks, all because of the imbalance system. Itself is a big science. I will deal much more elaborately when I talk to you people on the vestibular system. This is of the vestibular system. Now understand this much. Okay. So in the ear. Now today we'll discuss on the this is called all these three forms of peripheral vestibular system. Okay. Peripheral vestibular system or balance system. So today we'll discuss about the inner ear only. Okay. So, in a three-dimensional example, I am sitting. You are sitting and watching. So, how does the system goes? When you are sitting, see, these are the in semicircular canals. If you remember, there are the three semicircular canals. We had the three ampullary ends. One of the end is little bit dilated. Ampullated means dilated. Okay. In the ampullated ends of semicircular canals, where they meet the atrial. Okay. So, we have the end organ receptor. It is called as the cristae. Okay, in semicircular canals, at the ampullary end of the semicircular canal, we have the cristae. Okay, this cristae ampullaris, wherever action potential should, if it should generate means the air cell should, okay, move towards the capula. Okay, the movement of the air cells either towards or away gives rise to action potentials, and it rubs over the cupula, giving rise to action potential. So cristae, that is in the semicircular canal, gives rise to this gives the orientation about angular orientation. Okay, the angular acceleration whenever we move, this gives that orientation. Whether we are moving, we are just in a certain angle, angular. How to remember this? Ampullary end of the semicircular canal. Okay, so you can remember it as an angular. At the ampullary end of semicircular canal, since semicircular ampullary end, A for A, angular orientation. Okay, so whenever head rotates, the endolymph in semicircular canals also rotate, but head rotation is faster than the endolymph. So this makes the air cells to rub over the cupula, giving rise to action potential. It is ampulopetal rotation will be there, ampulofugal rotation. Okay. In atrial and sacral, what we have? The receptors are maculae. In atrial and sacral, we have the receptor which are called maculae. Maculae are like this. Okay. It has the air cells. Air cells are supported by supporting cells, and it rubs over the gelatinous substance producing the action potential. And incidentally, it has also calcium deposits over this gelatinous substance. We call it as a otolith. Okay, otolith, and itself is called as a otolithic membrane. So, when this rub over the gelatinous substance, action potentials are produced, and it is transferred via the vestibular nerve. Okay, we have the two nerves, superior vestibular nerve and inferior vestibular nerve. Okay, so from the semicircular canal and atrial and sacral, when the action potentials are generated, it travels to the vestibular nuclei. From vestibular nuclei, it reaches the central nervous system. Remember this vestibular nuclei, it has a lateral nucleus, medial nucleus, itself is a complex of nucleus. Okay, inferior nucleus and superior nucleus send the messages to the even to the cerebellum and ophthalmic. From here, it has a connection to the eyes and the spine, cerebellum. So all these three things are integrated here, and messages sent to the main central nervous system. Okay, and there the brain interprets. The brain interprets the signals and gives us the orientation about the orientation in this three-dimensional space. Oh, this is clear. Here you remember the aeroplane. One wing, and from the height, and another from the spine, vestibulospinal. Then cerebellum is also attached here. If these signals are damaged here, wait, I'll mark this. See, if the signal from here is a problem, the patient will tell rotation, chakkar aa raha hai. He will raise the fingers like this. If Signals from ear it is damaged. Patient will tell chakkar andere like it will be imbalance. Okay, in both ends. Okay, so घबराहट लग रहा है, चक्कर आ रहा है, but you will show is both ends. Remember the picture patients are suffering from the cerebellar part. This is the one observation what we have done. Okay, I think this is a clear for you people. I've simplified the physiology of hearing for you people. Hope you understand this. Understood this.